What are the things you've learned so far? Anorexia nervosa. Anorexia nervosa.
Yeah.
Okay.
Okay, Dr. Bruni, so you mentioned that binge eating is not
Mhm.
a feature for
No, I
bullying.
said it is
Yeah.
it is a feature. There's a subtype of anorexia nervosa, but
Yeah.
it is not the major feature.
Major type. It's a type of bulimia nervosa. The
Yes,
other
bulimia
features,
nervosa presents like that. And we also have
yes,
anorexia nervosa, a subtype of anorexia nervosa, which may present similarly.
may
However,
present, yeah.
that is not the
Yes,
main feature. Yeah. Dr. Idris, please
yes,
give us your
Okay,
yes.
thank you
summary
very
before
much.
we go.
Okay, yes. Anorexia nervosa is associated with a low BMI,
Mhm,
and weight intake, weight gain is part of its management,
mhm,
and is also associated with persistent restriction of food
mhm,
and intense fear of gaining weight. And we
mhm.
also find out of recent that numerical calculation is usually not affected in patients with anorexia nervosa, but rather verbal learning, visual learning, and visual ability can be impaired in people or patients who have anorexia nervosa.
Beautiful. Beautiful. Okay, let's go. Let's go. Okay. So you have a 25-year-old female with a history of anorexia nervosa who has recovered with weight but continues to experience intense preoccupation with food. The persistent preoccupation with food is most likely a result of A, inadequate initial treatment, B, long-term effects of starvation, C, comorbid personality disorder, D, unresolved body dysmorphic disorder. Doctors, what's your answer? Type your answers for me. Which, like somebody whose weight has recovered, but then the person continues to experience intense preoccupation with food. That intense preoccupation with food, what's the problem there? What's the problem there? What's the problem? Is it A, inadequate initial treatment? B, long-term effects of starvation? C, comorbid personality disorder? Or D, an unresolved body dysmorphic disorder? So you see, anorexia nervosa, oh, it's easy, it's easy, easy. Oh, anorexia nervosa. Oh, I just need to know that the patient is thin. I just need to know that the patient may have some calluses. No, 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 no. Anorexia nervosa goes beyond that. Right? So what's the answer? The answer is B. This persistent preoccupation with food is most likely a result of long-term effects of starvation. So persistent preoccupation with food can reflect long-term scars, which are caused by starvation, even after the patient has the weight restored. So the long-term effects of starvation has affected the patient's thinking, about food. Okay, next question. You have a 30-year-old male with anorexia nervosa. He presents with low libido and poor sleep. These symptoms are most likely due to A, primary psychiatric disorder, B, direct effects of malnutrition, C, comorbid substance use disorder, and D, lack of exercise. Why will you have a patient with anorexia nervosa who is a male have decreased libido, decreased sexual drive, and poor sleep? Is it because of the primary psychiatric disorder? Is it because of the direct effects of malnutrition? Is it because of comorbid substance use disorder? Or is it because of lack of exercise? What is going on there? What is going on there? Dr. Kano says C. Dr. Amana says B. Dr. Axani says C. What are the people here also saying? Dr. Ronnie also goes for B. Looks like so many people are going for B and a few people are going for C. What is the reason why somebody who has anorexia nervosa will have decreased libido and poor sleep? And the answer is B. It's because of the direct effects of the malnutrition. Malnutrition associated with anorexia nervosa can lead to symptoms like, so the malnutrition itself can lead to symptoms like decreased sleep, poor low libido. Okay, so please note that. So doctors, please, as we are going through it, learn the effects of anorexia nervosa. It can affect sleep, it can affect libido as well. All right, sure. Next question. This is a CDM. I need somebody to read this case for us. This is a CDM, please. Somebody to read the case for us.
Doctor, I can read.
Yes.
A 19-year-old female presents with a BMI of 15, intense fear of gaining weight, and restrictive eating patterns. She has a history of frequent self-weighing and avoiding social situations involving food. Question: which three interventions are most appropriate for initial management? Option A, cognitive behavior therapy. B, intensive inpatient treatment. C, antidepressant medication. D, nutritional rehabilitation.
Mhm.
E, family therapy. F, electroconvulsive therapy. G, self-help groups. And H is psychodynamic therapy.
Good. So this is a CDM. You've been
Yeah.
crying for CDM. Okay, I'm giving you one. Now, tell me, are you going for A? And you know the answer can be more than one, right? Don't forget that in CDM. So this one, it says which three interventions. So let me give you the trick here. If you choose more than three answers, even if you get three of those answers right, you get 0. So the question is saying which three interventions are most appropriate for initial management. So that means the answers you choose should not be more than 3. As soon as you choose more than 3, trouble. Okay, so that is one thing with CDMs. If the question is which 3 interventions, so that means don't choose more than 3 answers. So people are going with ACD. Dr. Kama went with ACD. Dr. Rajin went with AGD. Dr. Farah went with B. Dr. Amana went with B and A. Let me see the answers. Dr. Tin went with A, B, and D. It looks like Dr. Tin and Dr. Freddy agree. Dr. Michael went with A, B, and D as well. Dr. James went with D, A, and G. Okay, so what is the right answer? The right answer is A, B, and D. A, B, and D. Which 3 interventions are most appropriate for initial management? You have a patient with anorexia nervosa. What treatment is most appropriate for initial management? Cognitive behavioral therapy. Intense inpatient treatment, right? And then nutritional rehabilitation. These are the 3 things you want to start with in managing a patient who has anorexia nervosa. Now, CBT, cognitive behavioral therapy, is effective for treating the psychological aspects, while intense inpatient treatment is needed for severe cases with low BMI, and this patient's BMI is 15. So you can't let this patient go home. This patient needs to be admitted, right? And nutritional rehabilitation is crucial for weight restoration. So this is what is happening here. You have somebody who is in dire need. BMI is 15. Don't let the patient go home. Don't let the patient go home. This patient needs intensive inpatient treatment. Now, another question. A 25-year-old female with a history of anorexia nervosa presents with signs of relapse, including significant weight loss, excessive exercise, and social withdrawal. Her BMI is currently 16. What should be the immediate next step? Beautiful question. In her management. So you have somebody, it looks like maybe you treated her, the BMI came up to like 22, 23, and then the patient is regressing again. Now, the question is asking you, what's the immediate next step in her management? What is the immediate next step in her management? A, increase frequency of outpatient therapy sessions. B, refer for inpatient treatment. C, start antidepressant medication. And D, monitor the weight and reassess in 1 month. What is going to be your answer? Doctors, type in your answer. So, what is the answer here? Is it A? Is it B? Is it C? Is it D? I think a lot of the doctors are going for, what are they going for? B. Refer for inpatient treatment. And it looks like those on Facebook are also going for the same thing. And what does the literature tell us? B. Refer for inpatient treatment. Okay, so the best answer is you have to refer this patient for inpatient treatment. And the explanation is because given the significant weight loss and BMI of 16, inpatient treatment is necessary, because I've already said that, right? For close monitoring and intensive intervention. Okay,